Okay, folks. So we'll get started. Thank you for attending here today. Um, so you can see we're pretty somewhat broadly distributed in terms of uh, whether folks feel that we prescribe too many opioids as a profession or not. So let's try and we want to give you a clearer answer to this question during our discussion today. So I want to introduce Brooke Kenny and Caitlin Priest, who are really the stars today. They are members of Michigan Open, and Michigan Open, I can provide some resources after today when I send you the feedback survey, but there's a lot of resources for students and practicing dentists available for free through Michigan Open. And Caitlin and Brooke have contributed to a lot of the work in dentistry, which I'm excited about because neither of them are dentists. And so they'll be speaking today, and you'll get to know some of the great work that they've done. So let's get started. This is our the title of our talk is Using Big Data and Small Data to Understand Opioid Prescribing in Dentistry. So we do have a few disclosures here. Michigan Open receives funding from the Department of Health and Human Services. And there's a couple of, and that's what funded this project actually. And many people have helped us in our work in dentistry. Amongst this group, you'll see that I'm the only dentist, but you'll see that there's two D4 dental students whose names you may recognize, Chanel Thomas and Sarah Battag. And it's a tremendous multidisciplinary group. There's a transplant surgeon, a hand surgeon, a policy advocate, a lawyer, medical students. And so we're just really grateful for the support, the multidisciplinary support of what we're trying to accomplish, of what we're trying to accomplish in dentistry. So, let's start talking then about opioids. There's quite a large audience today, and we know historically when there's this many people together, that someone has been personally touched by the opioid crisis, whether it's in your family, whether it's you yourself or another close personal contact. But today, we're going to ask you to think a little bit differently about the opioid crisis. In fact, completely differently. Classically, what you've heard in the media is the narrative about the opioid deaths and the fentanyl deaths and all the addiction in our community and all the crimes that support those addictions. These are obviously very important issues, but today I'm going to ask you to think about what is our responsibility as a profession and as prescribers of opioids over the last decade. What has been our contribution to this crisis? So prescription opioids are frequently a gateway drug to heroin, and heroin is frequently the last opioid that a person becomes addicted to because it so often leads to death. Now, this is an important statistic. It's an important statistic because back in the 60s, more than 80% of people who entered treatment facilities for heroin addiction started their journey directly with heroin. Okay, 80% of people. So then in the 2000s, more than 75% of people who entered a heroin treatment center reported that their first opioid connection was actually a prescription drug. So you see that by prescribing, we actually have a huge influence on the modern opioid crisis. So heroin and fentanyl are so much further down the pathway. In terms of public health and in prevention, we should be thinking about what we're doing in terms of prescribing. In the end, the underpinning of this crisis has been overprescribing by health professionals. So this is a typical pathway for opioid-related mortality. You see that initially, someone healthy receives an opioid for a routine surgery. And one of the things I'm going to talk about today is wisdom tooth removal, which is one of the most common surgeries in America. So it's an otherwise healthy person, a minor surgery, and then they are prescribed opioids. Now, one of multiple things can happen. One is they can misuse that prescription of opioids. And then secondly, they may not misuse it themselves, but those opioids go unused or go into the reservoir of opioids available in the community, and someone else, a brother, a sister, a neighbor, can access those pills and they can misuse it. So this is a common pathway. So now I want to share some opioid mortality data from a few states. This is Colorado first. And I want to point out that non-Hispanic whites suffer from a high rate of opioid-related mortality. It's interesting to me because I've worked in public health research for a long time now, most of my career, and it's frequently minorities who end up suffering most from public health crises. All of the rules are broken with the opioid, with the opioid crisis. Here now is Indiana. Again, you'll see non-Hispanic whites have the highest mortality rate. Pennsylvania, again, the same finding. And Michigan, it's very high, no matter what your racial background, unfortunately. And then Massachusetts and Texas. Like I said, this is atypical for a public health issue that non-Hispanic whites are suffering the most. But at the same time, I want to put things in perspective for you also. Here's the nationwide mortality rate, 14.9 per 100,000 people. But I just want to put that in the context of some other public health issues like motor vehicle traffic accidents, heart disease, diabetes, and death from firearms. Something for you to think about is, all of the measures that we put in place, for example, for motor vehicle traffic accidents, police officers, red light cameras, speed cameras, seat belts, so many things that we do. But actually, there's a smaller mortality rate than related to opioids. And then same with firearms. The big movement in the opioid crisis really has just been in the last perhaps 5 years, whereas we've been working at these other public health issues for decades. Okay, so there's only 4 major points that we want to make today. Firstly, that dentists actually do prescribe a lot of opioids in answer to that first poll question, and we'll give you some real examples of that. Next, that opioids don't actually improve patient satisfaction, and that opioids aren't that effective for dental pain specifically. And finally, our latest study, which is, I think it's the cover story of JADA this month, and that is that dentists prescribe more just before weekends and and holidays. Okay, so the first study that we did that I'm going to talk about is a big data study, and so I have to give a little bit of information about that. This is a database that has about 50 million health insurance claims information, and it has medical side and dental side. So actually, let me ask this question, and you can put it into the chat here. What percentage of the opioids that are received by 10 to 20-year-olds are prescribed by dentists? You can put in the chat here. What percentage? 70, 55, right? 70, okay. 48, 25. You have to keep going till you get the exact number. No, I'm just kidding. So you're on the right track in that it is quite high. So it's actually about 33%, which is surprising. 10 to 20 age group, it's, to me anyway, it's quite surprising that dentists prescribe a third of opioids in that age group. So anyway, I need to define these two terms a little bit before we move on, okay? Opioid naive and new persistent use. So opioid naive, this is someone who has never had an opioid before. They're actually very much more vulnerable to misuse and addictive behaviors. And secondly, and so then, when you have 10 to 20-year-olds going to the receiving their first opioids, the vast majority of those people will be opioid naive. Secondly, new persistent users. So we defined a perioperative window of about 10 days around the extraction. And around that period, we thought it was reasonable to fill an opioid prescription. Now, any prescription outside the perioperative window without a new diagnosis, because remember, we have the medical and dental claims. So we know if there's been a new medical diagnosis, or for that matter, a new dental diagnosis. So any prescriptions outside the window, we considered new persistent use. And if they did have a new diagnosis, we kicked them out of our study group. We only wanted to look at people who had wisdom teeth removed, no other medical or dental problem, and then had new persistent use. So for example, we had some people still filling multiple opioid scripts 3 months after their wisdom tooth extraction with no new diagnoses. Okay, so in our database of 50 million, we found that there were 71,000 people who were opioid naive and were having their wisdom teeth removed. And what we found after evaluating them is that they were actually 2.7, they had 2.7 times increased odds of becoming a new persistent user. Okay, so let me tell you in percentage what that means, okay? But first I want to show you some context by showing you some medical data. Okay, so this is the percentage of people who went on to new persistent use after all of these different kinds of surgeries. The first one is minor surgeries, like gallbladder surgeries and things of that nature. So 6% of those people went on to new persistent use. Then the next is knees and hips, and about 8% of those people went on. Next is hand surgery. Now, hand surgery happens very infrequently. So the number is high, 13%, but it happens quite infrequently, less than 100,000 per year, that is. And then spinal surgery, again, 13%, and once again, not that common of a surgery. Next is pediatric surgeries, which was 5%, and then cancer surgery, 10%, and then major reconstruction after breast surgery, breast cancer surgery, I should say, it's actually 19%. So almost 1 in 5 people went on to persistent use. So now I won't get you to type it in the chat, but I'll get you to think about what number you might think it is for dentistry. Looking at all of these 6, 7, 8%, what percentage it might be for wisdom teeth that go on to new persistent use. Okay. Okay. So it's 1.3%. Okay. Now many of you might say 1.3%. That's nothing. What a letdown. But let's just take this in context, okay? Because wisdom teeth is actually by far the most common surgery in the United States. There's about 5 million wisdom teeth removed every year. This translates to about 2.2 million people. And 1.3% of that is actually still 30,000 individuals. So think about this. It's 30,000 people who previously never had opioids, went to their dentist to have their wisdom teeth removed. Now, I'm going to park the whole argument of whether we need to have wisdom teeth removed or not, and should it, some practitioners believe it should be case-based, others believe it should be routine. So I'm going to park that whole argument. So 30,000 people went to the dentist having never had an opioid and came out as new persistent users. So the answer to that question is, do dentists have a big impact? They have a massive impact. And this is just one procedure of all the procedures that we do. Okay, so now I'm going to hand over, Brooke, I think you're next. So I'm going to hand over to Brooke. I'll stop sharing. And here is Brooke Kenny. Brooke, you're currently muted.
Good afternoon, everybody. Let me just get my slides up and I will begin.
And if folks have any questions, just pop them in the Q&A and I'll try and track those and make sure they're answered.
Okay, good afternoon, and thank you for this opportunity and for taking the time to engage with some of our research. As Dr. Nalia mentioned, I'm Brooke Kenny. I am a data analyst with the Michigan Opioid Prescribing Engagement Network, and I'll be sharing a little bit about our quality improvement study that surveyed patients who underwent dental tooth extraction at the University of Michigan School of Dentistry. And this study was just recently published in JAMA Network Open in the March issue of 2020. So this is a familiar slide, but as Dr. Nalia was mentioning, what has come to light in the last several years is that a significant portion of opioid prescribed by surgeons to treat acute pain after surgery remain unused. And this leads to an excess of medication and contributes to the risk of new chronic use and allows the misused medication the potential to get out into the community. And while there is a large body of research demonstrating that meaningful reduction in opioid prescription can be appropriate for general surgery, the dental and the oral surgery data are more limited. And as we just learned, dentists are one of the most common prescriber to minors, and for many, this opioid prescription is the first exposure they will have to a narcotic. So this really puts dentists in a unique position to influence the fate of the opioid epidemic. Before I dive into our study, I just wanted to give you a quick background on Michigan Open. So we came together in 2016 to develop a preventive approach to the opioid epidemic in our state of Michigan by tailoring postoperative acute care prescribing. So in the last several years, we have partnered with the state's robust network of collaborative quality initiatives to gather data and implement change. And this change is to transform surgical pain management and to curb the opioid crisis. So we've led a series of research and quality improvement projects that examine the gaps in opioid prescribing after surgical procedures. And more recently, these collaborations have extended to U of M School of Dentistry under the leadership of Dr. Nalia. And as I mentioned, when it comes to evaluating the effectiveness of opioids prescribed for pain management, in the dentistry field, this data is a little more limited compared to what we have found in general surgery. So it was important for us to address this gap, starting with our own institution. So we looked at what are the prescribing habits and consumption within patients and looked at patient-reported outcomes. We surveyed adult dental patients that underwent a routine or surgical extraction between June and December of 2017. And this was truly a collaborative effort. We had a handful of research assistants working for MOpen at the time, as well as a couple of dental students, Sarah and Chanel in particular, who are on this manuscript, who made all these phone calls and talked with patients who did or did not receive an opioid prescription after their procedure. So to quickly run through the cohort selection, we made a systematic attempt to contact 1,300 patients. And after making exclusions based on those that didn't want to participate or we just couldn't reach, etc., we came up with a final analytical cohort of 329 patients. And just a quick descriptive of the cohort, those that underwent routine extraction, 39% filled and consumed at least part of their opioid prescription, whereas surgical extraction, this was just over half of patients. So when we set out to analyze the data, our primary outcome was self-reported pain, which was assessed by the question, how would you rate your pain after the first week of your dental procedure? And you could respond as having no pain, minimal pain, moderate, or severe pain. Secondary outcomes looked at patient satisfaction. So this was rated on a Likert scale of 1 through 10, with 10 being extremely satisfied. And then we also, for those patients that were prescribed an opioid, we asked how much of their prescriptions were consumed. And we converted all the prescribing and the consumption into 5 milligram tablets of hydrocodone. So when I say like tabs or pills throughout the rest of the presentation, that's the dose you can keep in mind. So here's what happened. We actually found that there was worse pain reported in the patients that consumed an opioid. So this bar chart is split into two groups with surgical extraction on the top. The non-opioid group is represented in the blue bars, and the orange bars are the opioid group. So those reporting moderate to severe pain, and in the opioid group, that was 64.6%, and only 45% in the non-opioid group. And the gap was a little bit wider for those undergoing routine extraction. So again, about 65% in the opioid group compared to 33% in the non-opioid group. With satisfaction, on the other hand, we didn't see a significant difference between the scores. And actually, our scores were really high between both procedures and in the opioid and non-opioid group. So good job, U of M dentists, with your scores. And this is a box and whiskers plot. So just to give you a little description, the X's within the box denotes the mean score, and the midline within the boxes are the median. So we had a median of 9 between non-opioid and opioid groups in the surgical cohort, and then it was actually up to 10 in the routine non-opioid group and 9 for the opioid group. So then looking at those that were prescribed an opioid, beginning with surgical extraction, we tabulated that this section of the cohort got about 1,500 pills prescribed, but only 831 of those were consumed. So this leads to an excess of 45% of those pills that were not consumed. A similar pattern occurred with the routine extraction group. Just under 1,000 pills prescribed, but only 520 were consumed. So about a 47% excess. So what are the implications of this study where we're showing higher reported pain among those that consume opioids and yet similar levels of satisfaction? So we do recognize that patient satisfaction is really a complex metric, given that patients may not be able to fully appreciate the technical competence that goes into treating their care. And while dentists are healthcare professionals, they're oftentimes small business owners, so it's really important for them to optimize client satisfaction, to protect and to grow their brand. So this study showing that there was really no difference between those that received or did not receive an opioid is really encouraging, and that it should hopefully take one thing off the plate of the dentist when they're considering, should I prescribe an opioid medication or not? These findings show that it didn't influence overall satisfaction. And the other thing we asked patients was if they made a phone call in the week after their procedure regarding pain concerns. And we found similar rates of phone calls in both the opioid and non-opioid group. This was about 12%. And there was no significant difference, which again, if the dentist is worried that their staff may be inundated with phone calls because they weren't treated correctly with pain management, this finding shows that, like, in this scenario, that wasn't the case. So again, should just remove that concern when thinking through if prescribing an opioid is appropriate for the patient. So what are some next steps that we can take with this study? So first, we recognize that the decision to prescribe is variable by clinician at the clinician level, and the patient's perception of pain can also be highly variable. That said, we really strongly encourage that a thoughtful preoperative discussion between the clinician and the patient about reasonable expectations may reduce the need for an opioid prescription after their extraction. So we know a lot about the pain that a patient can experience after dental extraction, and just the knowledge and the communication of what this intensity will be like and the duration that it will last could help the patient to feel more prepared to endure some amount of discomfort for a limited amount of time without opioids. The other thing we asked patients is whether they took non-opioid analgesics such as acetaminophen or NSAIDs after their procedure, regardless if they consumed an opioid or not. And again, we found very similar rates between the two groups, no significant difference. So this is just another patient education opportunity for patients that were going to receive an opioid that they really may not need it if they can use NSAIDs, acetaminophen, etc. as a first line to treat that acute pain. And then one of the studies that we reference in our paper also encouraged or showed supporting evidence that a 400 milligram dose of ibuprofen and a 1,000 milligram dose of acetaminophen taken concurrently was more advantageous than any other opioid medication. So these last 2 points go hand in hand. If prescribing an opioid is necessary, we encourage to consider reducing the dose or the number of pills that the patient receives for 2 key reasons. One, as Dr. Nalia was touching on, there will always be a risk that a patient with this new exposure to an opioid goes on to chronic use. So just lowering the quantity of pills that they would be intaking can help lower that core outcome. And then we also know that opioids have a tendency to bring on some unwanted side effects such as nausea, vomiting, constipation. And so again, lowering that dose or amount of pills that are in their system can lead to a quicker, more functional recovery. And then lastly, as we saw in our study, over 1,100 pills went unused. And so just lowering the amount of pills that we are giving out to patients can help curb the potential for misuse or for getting those pills into the wrong hands and out into a patient's family members or the community. And currently, there is no requirement for dentists to educate patients on safe storage or disposal. So again, just anything you can do to prevent the downstream effects of excess medication up front would be strongly encouraged. So what you are seeing now is actually a list of prescribing recommendations that MOpen has worked with other CQIs to come up with for the state of Michigan. And we evaluated these recommendations similar to the way we've done this dental study and looking at prescribing behavior and consumption, as well as digging into the literature. And so we just recently added dental extraction based on this study and other studies in the literature that support that non-opioid medications are efficacious. Right now we have it as 0 because that was to use NSAIDs or acetaminophen, as I mentioned, as a first line of treating pain. We are considering changing this to a range of 0 to 5 pills, as there will always be a need for patients, particular patients may need to have an opioid prescribed. Okay, just to touch on a few limitations of this study. Oops, I'm sorry. First, this was a retrospective analysis. So we contacted patients within 0 to 6 months after their procedure. So there will be some amount of recall bias occurring here, but we are thinking that if it does occur, it will be present in both the opioid and the non-opioid cohorts. Secondly, this was not a randomized study, so there could be unmeasured confounding within patient and provider characteristics that could influence the decision to prescribe or to use the opioid. This was also drawn from a single institution, so U of M. So these data may not be generalizable to other populations. And then lastly, as we saw in the cohort selection, there was a good proportion of patients that we just couldn't reach or didn't want to participate. So those data, although they went under the same procedure, we couldn't analyze their data. And that is all I have for you. Just wanted to say a big thank you to all of our study collaborators that worked hard to get this important message out to the community and to our partners and our funders. And that is it for me. Thank you.
Thank you, Brooke. So now over to Caitlin.
All right, let me share my screen. All right, so first off, thank you for the opportunity to share some of our research with you. So my name is Caitlin Priest. I'm a second-year medical student and a former research assistant at Michigan Open. And today I wanted to discuss our new study that recently came out in the Journal of the American Dental Association looking at opioid prescription fills around the weekends or holidays for outpatient dental procedures. So why is this important? I mean, obviously the United States has an opioid problem, and I don't need to explain the opioid epidemic to you, but you know, it's there, it's killing Americans, and some studies show, like Dr. Nalia had mentioned, that many people who use heroin initiated the abuse with prescription opioids. So given this, opioids should be considered more of like a last resort rather than first line. Dental procedures have the added bonus of being one of the most common reasons for first opioid exposures in children and young adults who can be particularly vulnerable. And while dentists only prescribe 8.6% of all opioids, like we had mentioned earlier in the age category 10 to 19, they write 31% of opioids for this group. Our group's previously done work that, you know, Dr. Nalia had gone over where those who filled an opioid post-wisdom tooth extraction had 2.7 times increased odds of new persistent opioid use compared to the group that did not. And then more recent literature looking at pain control after dental procedures found that ibuprofen and acetaminophen is actually more efficacious for some procedures than opioids. So the use of opioids following some procedures in dentistry may put patients at risk for adverse events like nausea, vomiting, constipation, and new persistent opioid use without any real benefit over potentially less harmful medications. There's also been some studies looking at time of day in prescribing. So opioids were more likely to be prescribed in a primary care setting as the day was going on or if appointments were running behind. And then similar studies saw the same thing for antibiotics. And then additionally for antibiotics, the likelihood of receiving a prescription increased surrounding weekends. And so we were curious if a similar pattern would hold true for opioids. And we hypothesized that for outpatient dental procedures, opioid prescription fill rates would increase before weekends and holidays. So this data is from Truven Health Market Scan insurance claims. We looked from 2013 to 2017 at patients ages 13 to 64. We required continuous coverage for 90 days before to make sure our cohort was opioid naive, and for 30 days after to make sure there weren't any additional procedures. We studied 11 common dental procedures, which are listed on the slide here. And then we also excluded the small number of weekend procedures in order to limit the irregularity in dental office hours. So overall, we ended up with just over 2 million patients that fit this criteria. So overall, 19% of patients went on to fill an opioid prescription, 81% did not. Females made up a slight majority of the cohort, and the largest age category was ages 50 to 64. There were more patients in the age group 13 to 29 that filled an opioid prescription compared to the group that did not. So this was 38 versus 26.5%. The most common procedures in this cohort were limited emergency exams, surgical extractions, and routine extractions. And surgical extractions accounted for 49.1% of procedures in the opioid group, but only 8.2% of procedures in the no opioid fill group. We also noted that there were significantly more patients with a procedure the day before a weekend or holiday in the opioid group when compared to the no opioid group. So this was 21 versus 13%. We found that the adjusted odds of filling an opioid was 27% higher in those with procedures the day before a weekend or holiday, and this difference was significant. We also saw that when compared to other age categories, the youngest age category, so patients ages 13 to 29, had the highest odds of filling an opioid. Procedures with the highest odds of filling an opioid included surgical extraction, alveoplasty, and apicoectomy. This figure shows the unadjusted opioid fill rates stratified by either day before weekend or holiday in blue versus other weekdays in green, and stars mean significance. So you can see that for patients seen the day before a weekend or holiday, in all procedures except for apicoectomy and alveoplasty, they were more likely to fill an opioid. The largest difference was in opioid fills for surgical access of unerupted tooth, where patients that were seen the day before a weekend or holiday had a fill rate that was 10.8% higher than those seen on other weekdays, and surgical extractions followed close behind that with a 7.6% difference. In summary, outpatient dental procedures that occurred on a day before a weekend or holiday had 27% increased adjusted odds of filling an opioid. And this increase was seen in all of the procedures that we studied, so it's not just driven by one procedure or one condition. It's possible that this increase surrounding weekday or weekends and holidays is due to either patient or dentist concern for uncontrolled pain or limited access to after-hour cares for emergencies. The dental profession has a lot of small and solo practices, and many dentists don't work on weekends. So in our study, we did see that most procedures were done Monday through Thursday, but we saw significantly more patients with a procedure the day before a weekend or holiday in the opioid group when compared to the no opioid group. This may be due to preferential scheduling of more complex procedures to allow for time for recovery over the weekend or holiday. It's also possible that with the increased risk of after-hours emergencies, patients and dentists may have concerns about limited access to care, which may make dentists more inclined to prescribe an opioid just in case, and it may also make patients more inclined to fill that opioid. Preemptive prescribing in this fashion is unwarranted, though. There are studies showing that opioid prescription sizes don't correlate with patient satisfaction or pain or fills that we touched on earlier. And overprescribing like this can lead to unused pills in the community that are available for misuse and abuse. There are a few guidelines for the dental profession. So for example, the ADA only lists 10 on their website. And the limited number of clinical practice guidelines combined with the fact that most oral health care is delivered through small and independent practices can result in high variability in care delivery. So from 2012 to 2017, the number of dental opioids has decreased from 18.5 million to 18.1 million. But in the same time period, the percent of all opioids that were provided by dentists has actually increased from 6.4% to 8.6%. So, why is there this discrepancy? It might be a sign that recent policy changes aren't reaching all specialties equally, and there might be gaps for improvement in dentistry. Many states and professional organizations have guidelines for prescribing opioids, but many of these just choose to limit the number of days of the prescription. So for example, the ADA supports providing 7 days or less for acute pain. And this is a step in the right direction, but these kinds of policies still permit variation and the potential to overprescribe even within the limits of the policy. Procedure-specific guidelines based on patient-reported outcomes have become popular in other surgical fields, and so they may be a resource for dentists when making the decision whether or not to prescribe an opioid. So as Brooke had mentioned, our group is actively working on adding evidence-based guidelines, so if you were interested, you could check them out at this link and subscribe for updates. So in other surgical specialties, we've seen that preoperative patient education on the risks of opioids reduces postoperative opioid use and also decreases pain scores. So we would like to propose that dentists strive to discuss expectations about pain management and the risks of opioids with each of their patients prior to their procedure. Clinical trials and systematic reviews have questioned the regular use of opioids for common dental procedures, with some suggesting that for some dental procedures, over-the-counter alternatives are more efficacious. So we believe it's important that dentists discuss the proper use of over-the-counter pain relievers like ibuprofen and acetaminophen with patients when it's appropriate. Some will argue for around-the-clock dosing of these medications to try and avoid the need for opioids. We also saw that there were significantly more patients with procedure the day before a weekend or holiday in the opioid group than in the no opioid group. So this may be due to preferential scheduling of more complex patients before weekends or holidays to allow for more recovery time. But we would like to propose that procedures with concerns for postoperative pain or complexity should actually be scheduled earlier in the week so that recovery might be better monitored. Another alternative to this would be to create office partnerships to rotate on-call duties for emergencies on weekends and holidays. Our limitations include the fact that our analysis only captures opioid prescription fills and doesn't capture patients who got a prescription but chose not to fill it. We also don't know what counseling was like around their prescriptions. And some procedure codes like limited emergency exam are used without a consistent way to indicate procedure injury severity and might represent a group of patients with varying pain control needs. All right, so thank you again for the opportunity to share some of our research. So if you were interested, the article is online now and should be in print soon. And if you want to know more about what Michigan Open does or browse some of the dental resources, you can go to michigan-open.org. All right, thank you.
Thank you, Caitlin. So folks, I will invite your questions. We have some time for that, but I'll just round up with some comments. So first of all, I'm so very proud of Caitlin and Brooke and so grateful for all of their work. The research that they've driven is going to change the way we look at opioid prescribing in the dental profession. And they're not even dentists. So I'm just so proud and grateful for their efforts in our field. And you know, this study that Caitlin just described, where you know when you have a medical surgery, you know a lot of minor medical surgeries are comparable to complex wisdom tooth removals, right? But when you have a medical surgery, you don't necessarily say, "Oh, let me do that on a Friday so that I don't miss work." But we are often told this as clinicians, and the idea for this study came because I know historically I've been guilty of this as well, is to book the complex procedures on a Friday and load people up with opioids. And the thing is, now that we know better, we need to change our operations and start to do those things on Mondays and Tuesdays so that we have time for follow-up. Because you know, it is this societal devaluing of dentistry. And you know, I think that Caitlin and Brooke have done a lot to reverse that. And hopefully we in our profession can continue on that good work, because it has these very significant impacts, including overprescribing. When people as a society don't value dentistry, they're not demanding, you know, the general surgeon to do their laparoscopic colectomy on a Friday, right? They're happy to do that whenever that's scheduled, but we are asked to do things like this day in and day out. So anyway, I'll invite any questions at this stage. If there's no, well, there's a question here, but I was just going to say there was another thing that Brooke and Caitlin kind of touched on, and that is about opioids being the last resort. And this is another thing that I myself am guilty of, and I think our profession is guilty of as well, is we go straight to prescribed medicine, right? So something we're very proud of is that Michigan Open actually co-wrote the guidelines for dental prescribing in Michigan. So if you go to the LARA website and search dentistry opioid guidelines, we contributed to that. And what's important about that is that opioids is literally the last line of defense, in that it's one of the first times in a dentistry guideline that we've brought in mindful meditation, acupuncture, and various other non-pharmaceutical approaches. So I'm very proud of that, because the thing is, at least I'm guilty of this, we haven't historically engaged in these conversations with our patients to say, are you someone that's open to managing pain without pharmaceuticals? A lot of our patients would say, yes, I don't want an opioid. I don't even want an ibuprofen for that matter. I'm really glad that we're starting to look at those areas, because I should add, there's a lot of evidence for that, and so for the right person, that can be highly effective. So anyway, let's check out these questions. So Jennifer asked, both presenters mentioned the use of ibuprofen and acetaminophen for better pain relief than opioids, specifically 400 and 1,000. Did any of the studies look at different dosage? Was there a statistical difference that indicates this combo dosage? So actually this data is not from our research, specifically looking at a comparison of opioid versus ibuprofen and acetaminophen. This is Paul Moore's work. I think he's in Pennsylvania, maybe, and it was a systematic review of a group of studies that actually measured concurrent staging. Now, historically, I graduated 20 years ago, but historically, what I was taught was alternate staging. So acetaminophen and then ibuprofen. But actually now some of the literature is looking at concurrent staging, so taking them together. And so Paul Moore's systematic review uncovered that that is actually equal or more effective than any opioid mix. So that's extremely powerful, because, the thing is, we don't have these kinds of studies for other fields of medicine. So dentistry is privileged that we have these studies showing that over-the-counters are actually more effective. Okay, Dr. Bain is here. That's great. Dr. Bain is the retired chair of CRSE and my first boss, actually. So thanks very much for the job, Dr. Bain. But is opioid threat via dentistry about the same internationally or worse in some countries? Oh, this is great. This is a great question. And Caitlin and Brooke, please chime in if you like. Sarah Batag, Chanel Thomas, myself, Caitlin Hargood, and a few others, we're working on this study looking at this exact question, because opioid mortality is much lower in some other countries without necessarily the controls that we have. And I think, so actually I can speak about Australia. Now, I should warn that actually the trends are similar in that there is an upward trend. However, their starting point is way, way, way lower than us. And there is a cultural difference in expectation of pain. And, this is a whole separate lecture, Dr. Bain, but in the United States, I think it was in the 90s, the Institute of Medicine started talking about pain as the 6th vital sign, right? And that we should address pain as aggressively as we address high fever. Okay, and then subsequent to that, so when patients have pain, that affects that may be perceived to affect satisfaction, right? And so then in the early 2000s, Medicaid started reimbursing hospitals differently if they had a better satisfaction rate. So I think that's another factor that drove this feeling that pain must be eliminated, as opposed to, pain needs to be managed. Because in Australia, there is definitely a different culture, although the US and Australian cultures are similar in many ways, but there's definitely a different expectation of the patients that I had in Australia to do with post-operative pain in dentistry. So Dr. Tyndall, since your study was non-randomized, and I'm not sure which study, but anyway, let's keep it non-randomized, retrospective, how do you conclude that non-opioids and opioids are equivalent for pain relief in third molar surgery? No, I don't think that was the conclusion, actually. Sorry, let me keep reading. Wouldn't your data be somewhat affected by surgeons prescribing non-opioids and less extensive procedures? Okay, so I think there's one particular thing, and I think, Brooke, this is something you describe. I don't know if you want to address this at all, Brooke. It is the, the table where as you go to higher ratings of pain, the patients with opioids are more likely to describe higher ratings of pain. It's that diagram. I can talk a little bit about it, and then you chime in if you want. Because the wisdom tooth study was a big data study, so we don't have refined data about specific patients. But Brooks' study is about extractions, so that's broader than just third molars. But I think what Dr. Tyndall is getting at, this is a good point, because there's two things to think about. Hey, Brooke, would you mind bringing up that slide of the patient satisfaction? So basically, we found when we call back patients that the patients who described the most pain, they were also the ones most likely to have taken opioids, okay? Now, there's two ways to look at this. One is that we are prescribing opioids so effectively that it is the most complex procedures that are getting the opioids, and then those patients, because the procedures are so complex, they're describing pain anyway, okay? So that's one way to look at it. However, the other way, and I think a more plausible thing, because it's supported by research, it's supported by Paul Moore's study, is that opioids are not that effective for dental pain anyway. And so when you have severe pain, those people are the ones taking opioids because the opioids don't seem to be working effectively for dental pain anyway. Now, it is a valuable backup. For example, if someone has some issue with ibuprofen, non-steroidal anti-inflammatories or whatever. However, I don't think it can no longer be touted as the primary option in pain management in dentistry. Okay, so I think that's all from the questions. Caitlin and Brooke, do you have anything to add at all? You might be muted. I'm not sure if you're speaking.
I don't have anything to add. I hope you can see I brought up the pain scores. So, but you're right. Without a randomized control trial, there is definitely opportunity for bias within this study. So we did want to call that out.
Yeah. And Paul Moore's systematic review does include randomized control trials. Yeah. Okay. Well, folks, thanks again for attending. Thanks for your attention. It takes the CE office about 2 weeks to process these CE credits. So we'll move that along as quickly as we can. And please look out for a feedback survey from me. And please give us your feedback so that we know how to improve things. And thank you. Have a wonderful Friday and an excellent weekend. And hopefully no one is having a dental procedure today. Okay, bye-bye.
Yeah, thank you. Bye-bye.